I have voting slides. So please open your app, because we're already a small group, so we can at least have some interaction. And you can participate, at least in the discussion, by voting. I have no disclosures for this presentation, and I start with my first voting slide. And that's the question on how is perfusion of organs regulated in normal conditions. So we're not talking about sepsis or cardiogenic shock or stuff like that. So how is tissue perfusion regulated under normal physiological conditions? A, by adapting cardiac output, by adapting the blood pressure, the topic of this session, by changes in venous return, or by regional vasodilation.
We vote.
Sorry?
We are voting.
Yeah.
Yeah. Please. Yeah, only one
You
possibility.
can only choose one. Yeah.
Sorry.
Yeah.
Okay. Boom.
D. Okay, so the majority thinks that by regional vasodilation, the circulatory system is manipulating organ blood flow. So why in the world would blood pressure be important? If the mechanism is vasodilation, which decreases pressure, why would the systemic pressure in the system be important to optimize tissue perfusion? And I think...
Take your microphone, please.
Sorry?
Take your microphone.
Oh, yeah. And so I think that if you have a normal blood pressure but you don't perfuse, you will die. If you perfuse but you don't have a lot of pressure, it's very unlikely that you die. And so that's the controversy we're talking about. I think the majority is agreeing that vasodilation is the way we manipulate. And so the question is, why pressure? Is that true? I mean, it's very easy to check this in animals, but incredibly difficult to do this in patients. And so what we did is we went to the OR and we used speckle imaging. And speckle imaging is a measure of flow, but not like liters per minute. It's an abstract number that you get. And we placed the speckle imaging probe on the brain of the patient. And as you know, before you do brain surgery, you do functional MRI and you find out where speech is located and other functions are located, so that by removing the tumor, you're not destroying speech or whatever, let's say, function that's important. And in this MRI, we located the function where you do this. And so during brain surgery, we placed the speckle imaging probes on the brain in the region where the neurons regulate this action. And I think we all agree that if you do this, your cardiac output will not change and your blood pressure will not change, especially not if you're in OR conditions. So there is nothing going on with systemic blood flow. Now, when you ask the awake patient, because this is awake craniectomy, if you ask these patients to do this, then look at the, let me see if this works, yeah. Then look at the area, what flow is red, so the more the flow, the more red you see. And so if you ask these patients to do this, you see an immediate increase in this area where the neurons are located that control the activation of the muscles that make you do this. That's an immediate effect. There can never be an adjustment of blood pressure, there can never be an adjustment of cardiac output, there can never be an increase in venous return. This is local vasodilation. Immediately, just before you start to do this, you have an increase in blood flow. So this is a demonstration that answer D is correct. We regulate the perfusion of tissues by local vasodilation. The problem is when we get into trouble, and so let's say trouble shock, another system kicks in, and that's your sympathetic nervous system. Your sympathetic nervous system tries to maintain blood flow to relevant organs, like your heart, It's very good if you're in stress that your heart keeps working, and your brain, so that you can make decisions. And this is, of course, old stuff. So if you need to run for a lion, it's completely inappropriate that you have to pee. So the first thing that shuts down is your kidney perfusion. It's very inappropriate that you have to poop, so your gut perfusion will shut down immediately. But it's incredibly important that you keep venous return going, and that your brain keeps going to make the right decision. So that's the effect of your sympathetic nervous system. And so what we see in patients that are in shock is that they shut down irrelevant circulations, like, for instance, the skin and microcirculation in the skin. And so this sympathetic tone increases your blood pressure, as you can see in this cartoon, the red one, in this case. So in the first stage of, for instance, hypovolemia, your sympathetic nervous system increases your blood pressure. There's the normal fall over your system, so going from your aorta to your precapillary sphincter. And this box is the microcirculation, and this area of the box is the entry pressure to the microcirculation that we cannot measure. So mean arterial pressure, I think it's a frequent misunderstanding. Mean arterial pressure is not the pressure at the beginning of your microcirculation, because that's the pressure behind your Starling resistor in the organs that have a Starling resistor, of course. And so if you have a high mean arterial pressure, like in hypovolemia, the vasoconstriction shut down your precapillary sphincters, and basically the entry pressure to your microcirculation is close to zero. That's why patients with severe hypovolemia and low flow shock have this discolored skin, they have prolonged capillary refill time, and they have an increased delta temperature and stuff like that. They shut down their microcirculation. And it's not that this is not present in septic shock. In the Andromeda shock study we showed, published in JAMA earlier this year, we showed that increased capillary refill time is present in a large group of patients with septic shock. So this is not only hypovolemia, bleeding, or cardiogenic shock, but also sepsis. And so if you have this precapillary sphincter constriction, your microcirculation shut down. If you open up this sphincter, like in the normal physiological regulation, your perfusion pressure over your microcirculation will actually increase. So if you go into a vasodilatory state, this entry pressure will increase. And that's why patients that are vasodilated are bright red and very warm. They don't have this discoloration that Aitufella from France described. They don't have that anymore. If you use a vasodilator, you can completely make these discoloration disappear very rapidly just by opening up this precapillary sphincter and increasing the perfusion pressure of your microcirculation. However, as Thomas already alluded to in his answer, if you have arterial vasodilation and at the same time you increase venous pressure, so the pressure at the end of your microcirculation, then basically the advantage of having a higher entry pressure is diminished by having this higher venous pressure. And of course, central venous pressure is not the pressure at the end of your capillaries, because if that were true, there would be no flow. The pressure at the end of your capillaries is always higher than your central venous pressure, otherwise there is no venous return. And so the mean systemic filling pressure that you can estimate, we cannot measure it, but we can estimate, is a better reflection of end capillary pressure. And we know that if you increase, by whatever blood pressure you have, if you increase this pressure, you will decrease perfusion. And the group from DDAPM was the first to allude to the CVP 8 to 12 area in the earlier surviving sepsis guidelines, showing that it was associated with an increase in new acute kidney injury. Namke Vellinga, a PhD student of ours, at that time located in Leeuwarden, did a study on how are these venous pressures related to the microvascular flow index in the sublingual microcirculation. And basically she showed the same. If you have an increased CVP, an increase in this context is more than 12, your mean circulatory flow in your sublingual microcirculation is significantly lower than when you have a low CVP. And so increasing this CVP, whatever the blood pressure, because in this study of Namke, blood pressure was within the limits, and the usual blood pressure in septic shock studies is around 70, not 65, but 70. Even in the Pierre Asfar study, where they tried to have lower and higher, it was still around 70, 75. And so the blood pressure in these patients is the same, but the determinant for microvascular blood flow is, in this case, CVP. We repeated it in another context. We looked at patients with cardiogenic shock. Paper is just published a few weeks ago. And we looked at new acute kidney injury, the same as the group of DDAPN. It's retrospective, so be careful. And we looked at new onset of acute kidney injury in patients with cardiogenic shock. And we found that CVP, an estimate of end capillary pressure, was the best and the single predictor of new kidney injury. The difference between the two groups, the groups without acute kidney injury and with in CVP, was only 3 millimeters of mercury. And so the tolerance of, in this case, the kidney for small changes in CVP is extremely limited. And it's not like when we started all this, the cardiologist said, oh, CVP of 20, that's because the heart is failing. Yeah, that's true, but that has significant consequences in real life. And as you can see, 15 is already close to what the surviving sepsis guidelines initially proposed in patients on ventilators. And CVP of 12 is already close to what the group from DDAPN and Namke Vellinga found. And so be careful with this. I have a good blood pressure, but my CVP is a little bit increased. You have to assess both sides of the microcirculation. So next question, and that's more about physiology and the confused publications in literature. So these are two graphs, A and B, and the question is which relationship between pressure and flow, and there is normal and patient with chronic hypertension. So which one is the correct curve, A or B?
I like it. I like this.
Yeah, great. We're all lost. We're all lost here. Because if you look at graph A, then think about what this suggests. Remember the first slide? How do we regulate tissue perfusion? By vasodilation. And how is tissue perfusion regulated? With metabolic activity. And so this slide suggests that at the same blood pressure, patients with chronic hypertension have a higher organ blood flow, which is of course not true, because we don't regulate organ blood flow by manipulating blood pressure. That's not the way it happens. We regulate blood flow by demand. And so whether you're chronically hypertensive or chronically not hypertensive, it has no impact on the regulation of blood flow, because blood flow will only increase if you have metabolic activity, and blood flow does not go to a higher level just because you have chronic hypertension. So curve A is physiologically not correct, it's curve B. So you have a shift of your curve, and so the autoregulation area in chronic hypertension shifts, but not to a higher level, but at the same level, of course, because organ blood flow is not regulated by blood pressure, and we have to be very happy with that, because if we would need to manipulate blood pressure to, let's say, regulate organ blood flow, the brain would explode. And so you run up the stairs, and halfway the stairs you would be dead because you have brain herniation. So that's not how it works. The autoregulation is a safety mechanism. It's to protect us from hyperflow in the high regions, and to protect us a little bit in the low flow region, in the low pressure regions when we are in shock or whatever. But remember, in the basic brain functions, in regulation of flow and pressure, and in the animal kingdom, it's very uncomfortable to have a long death. The maintenance of blood flow is just to be able to escape and run for safety, and if not, then die as soon as possible. There is no, let's say, survival in multiple organ failure in animals. That's not the way physiology works. And so the shift of the curve is to the right and not upwards. Okay, next question. Low blood pressure can be normal. Very simple question, yes or no?
What do we win if we have all responses correct? We get the prize, we get the tickets to go somewhere.
You get my grace.
Ah.
I will thank you personally.
Oh, that's great. That's great.
So, I don't see the answer. 100% agree. That's not okay. Low blood pressure is always pathology. I think what you meant by answering yes is low blood pressure can be adequate. I completely agree. You can have a low blood pressure and be completely adequate. But you can not have a low blood pressure and have normal physiology. There is something wrong with patients with low blood pressure, and that's why it's so powerful. If you measure a blood pressure in the emergency room and it's very low, you and your patient are in trouble. If you measure a normal blood pressure or even an increased blood pressure, it doesn't tell you anything. The patient can be dead in 15 minutes. But it can also be a simple case and the patient goes home tomorrow. So I think the message is a low blood pressure can be acceptable and related to good survival, but it's not a normal physiology. There's always something wrong. Now, massive vasodilation, as we see in septic shock, so these very low blood pressures, that's absolutely a risk factor. All these studies that Thomas showed you show that if your blood pressure is low at a very low level or for a prolonged time, that always results in more mortality or more morbidity. The question I always have with these numbers is, this is epidemiology. And there is a difference in epidemiology. If I have a patient with a blood pressure of 55, and I very strongly think that this is completely inadequate, and I try to get it to 65, which is the guideline, and I can't. Whatever I do, I try 55, I give epinephrine, I give phenylephrine, I give angiotensin, and nothing happens. I've never seen anyone survive. If I think they need 65 and they're at 55, I cannot get them, they're dead. But if I have a patient at 55 and I think, well, this is okay, nothing wrong, well perfused, lactate is normal, the patient is peeing, the patient is talking and communicating, and I don't try to get them to 65, nothing happens. They go home happily. And so in the epidemiology, there's one very important thing missing, and that's what's the goal, what's the intention of the doctor at the bedside? Does the patient really need 65, or is there a failure to get them to 65? And so there is no question that massive vasodilation and low blood pressure is a risk factor, but if you try to dissect where does this risk absolutely start, which is, of course, impossible in human beings, you might be surprised. And the group from Austria did an interesting study to try to get to the bottom of all of this. It's, of course, retrospective. And so what they did is they measured the blood pressure and the changes in blood pressure in patients that rapidly died, and assessed the blood pressure at the start, just before circulatory arrest. So this was not ventricular fibrillation and myocardial infarction. So this was a progressive hypotension. And then at one point you had an arrest of the circulation, and they looked at the blood pressure at that point. And they found that if you look at mean arterial pressure in patients with sepsis or on vasodilative drugs like sedatives and opioids, let's say the critical mean arterial pressure to go into cardiac arrest and circulatory arrest is 35 plus or minus 11. And systolic 47 and diastolic around 30. So that's an extremely low blood pressure. And I'm very bold with blood pressures. I accept very low blood pressure, but I would be extremely uneasy with a mean arterial pressure of 35. And so there is no discussion that low blood pressure is not okay. We have let's say, limited knowledge on what is completely unacceptable. And if we touched upon diastolic blood pressure a little bit with the previous speaker as well. We started a pro-con debate on diastolic blood pressure, and it was started in a discussion we had, I think it was in the Paris meeting, where Jean-Louis Teboul and Sheldon Magder discussed about blood pressure and diastolic blood pressure. And Sheldon said, this is all bullshit. I don't give, I'm not interested in diastolic blood pressure at all. Whereas Jean-Louis Teboul said, well, no, you have to treat diastolic blood pressure because that's very, very important. And so I asked them to write a pro and con debate on this, and they completely disagree. And so where Sheldon Magder, and he's very physiology-oriented, and they're good friends, so there's no animosity between the two, where Sheldon Magder said, I mean, who cares about diastolic blood pressure? Jean-Louis Teboul says, well, if it's less than 45, you have to hurry up with your vasopressors to get the pressure up. And so even the even more let's say, experts on this topic don't agree on this. So that's not easy. There is no easy answer. And in my practice in NYU Langone in New York, it is very easy because they treat by guidelines. Whereas in Chile, where I practice, we treat by physiology. And so the blood pressure is all over the place. So there's not a lot of guidance. So the question is your blood pressure target context dependent? So if there is no guidance, is there at least guidance in septic shock? I do something different than in cardiogenic shock. Yes, very good. Of course, the blood pressure is context dependent. I always ask my audience, did you ever see anyone die of spinal shock? I mean, we still call it spinal shock, but did you ever see anyone die of spinal shock? The low blood pressure you get when you have spinal injury, I've never seen any mortality. It's a very simple to deal problem that you have. We call it shock, but basically, to be honest, I've never seen anyone in shock, in spinal shock. So, of course, it's context dependent. I get much more worried with very low blood pressure when the cardiologist hasn't opened up the coronary artery in cardiogenic shock, than in septic shock, where you have this warm and well-perfused patient with the falling lactate and urine production, for instance. So yes, of course, your blood pressure target, like we said in the guideline, should be individualized. It's context dependent. And for instance, if you look at the microcirculation and you resuscitate the microcirculation, the context is very important. This is a study we did where we compared a very simple form of shock, a low output shock due to venous congestion, the tamponade. So in the tamponade model, you combine two elements. You get a low flow and you get an increased venous pressure. And we compared it to septic shock. And as you can see, if you, so this area is the area where we decrease the cardiac output to 50% of baseline. In septic shock, it's just weight. It's very simple. Remember, every septic shock is a low output shock. The high output is created by us, but that's not septic shock. So we wait until cardiac output is 50% of normal, of baseline. And in the tamponade, we just infuse fluid in the pericardium until you have a 50% cardiac output. Then in the tamponade, you remove the fluid, and in the sepsis, you give fluids. The thing that we do in clinical practice, and see that the flow in the microcirculation in the tamponade model immediately returns to normal. They don't need fluids. I've had many discussions with cardiologists and patients with tamponade, and they say, give some fluid to increase cardiac output. No, of course not. Insert a line in the pericardium or open the pericardium, get the fluid out. Don't do fluid resuscitation, that will never help. And so, yeah, you will have an immediate restoration of your microcirculation, but not in sepsis. If you return the cardiac output to normal, there is no restoration of microcirculatory shock, and the blood pressures in these is the same. And so, yeah, there is a difference in context. The sepsis patients is not the same as other patients. And when the patient already has a normal microcirculation, then who cares about the blood pressure? Or who cares about increasing blood pressure? Because blood flow, because nothing will happen. This is a study Eva Klein did in Rotterdam. We looked at whether vasoresponsiveness needed fluids, a complete misunderstanding in current day practice. If you have a patient in shock, then fluid responsiveness needs to be corrected to fluid unresponsiveness. That may be true if the patient might benefit from an increase in cardiac output, but if the patient already has normal microcirculation, that doesn't make any sense. So in this study, these are the responders, so the fluid responsive patients. These are the fluid non-responsive patients. And increasing blood pressure has no effect on your microcirculation because 3 MFI is already normal. And so basically the only thing you do is make these patients hyper, even more increased flow in your microcirculation. We even had to add 4 to the microvascular flow index. The normal range is 0 to 3, and we had to add 4 because we had all these patients with these huge increases in microcirculatory blood flow. And I think hypercirculation in your microcirculation is not beneficial. So yes, there is context. And so if your patient is well perfused, then the blood pressure is much less important than when your patient is not well perfused. And that's the point, and that's the interesting point that Arnaldo Dubin made in this study. If you have low blood pressure and you increase blood pressure, and this is 65, so the low limit of the guideline, 65, and you increase it to 85, the patients that benefit are the patients with abnormal microcirculation. If you have normal microcirculation at 65, then increasing blood pressure doesn't make any sense, at least in this study by Arnaldo. And so I think the approach you should have in shock is, what is my clinical problem? And remember, blood pressure is not a clinical problem. Blood pressure is a sign that there is a clinical problem, but it doesn't tell you what the clinical problem is. And correcting the blood pressure is foregoing all the relevant problems that you need to address. That's just fixing a number. And then the question you have to ask yourself, okay, this clinical problem, would it be solved by improving perfusion pressure, so increase the blood pressure, or improving flow, cardiac output, or the distribution, or both? Maybe I should both increase the blood pressure and the cardiac output. And then you have to ask yourself, is this improvement in tissue perfusion or perfusion pressure best achieved by increasing the pressure before the microcirculation, and the only surrogate we have is blood pressure, or lower the pressure at the end of the microcirculation and lower the CVP? Well, my first response in a patient with a CVP more than 15 in shock is not increase the blood pressure, but lower the CVP. And then the second, if you want to increase cardiac output, what's the best way to do it? And finally, check whether it helped, check whether it worked. So, next question. When would you immediately start a vasopressor in septic shock? So let's assume a patient in septic shock is wheeled into your ICU, hooked up to the monitor, and you get a blood pressure. Now, when would you immediately start a vasopressor? When the MAP is less than 65 and abnormal peripheral circulation, MAP less than 50, even in a warm patient. Never, always give fluid first, or when the diastolic is less than 50. That's interesting. So half of the audience would immediately give a vasopressor if there is, let's say, a blood pressure lower than the guidelines, and there are signs of abnormal peripheral perfusion. For me, that would be a limitation. I would not start a vasopressor in patients with already shut down microcirculation because they're already constricting. And so my objective in patients like this would do something to increase the flow, because abnormal peripheral perfusion is an indicator of abnormal vasoconstriction and limited blood flow. And the group from Austria showed that if you have abnormal peripheral perfusion, the perfusion in your gut, your kidney, your liver, and your spleen is decreased. And the more your capillary refill time is increased, so the more vasoconstriction you have, the lower the perfusion of your abdominal organs. Adding more vasoconstriction to this system, that would not be my first choice. I would try to do something about flow and try to increase cardiac output. And the opposite, when the mean arterial pressure is less than 50, but the periphery is normal, I would not be inclined to start a vasopressor immediately. Never, always fluids first. That's a small group, a fifth of the audience. That would not be my first action as well. And if it's I would definitely start fluids if I think that the patient is fluid responsive. That's true. And diastolic arterial pressure less than 50, we get into the discussion between Sheldon Magder and Jean-Louis Teboul, and we try to let's say, work with this. How important is it that you have a low diastolic arterial pressure? Because if it is low, of course, you have a severely ill patient. And so what Gustavo Ospina from Colombia did with our database of the Andromeda shock study and the database he has, is we came up with the diastolic shock index. And the diastolic shock index is like the shock index systolic arterial pressure and heart rate, and so this is diastolic arterial pressure and heart rate. And when you look at the diastolic pressure in this 760 group patients in septic shock, is that there is hardly any difference at baseline and for the first 4 hours in diastolic arterial pressure between the two groups. It's only at the end of this first 24 hours that they separate. And the non-survivors cannot maintain an increase in diastolic blood pressure. When you then look at this diastolic shock index and you correct for the use of norepinephrine, you see an enormous difference between non-survivors and survivors. And when you look at the mortality, we came up with a cutoff of 2.2. And so you can see that if you have a diastolic arterial pressure with a very high heart rate, that's a bad sign. And I think you all remember this from clinical practice. When you see these patients with low diastolic blood pressure, but with a heart rate of 85 or 90, that's usually a much lesser problem than when they have 150. And that's reflected in these data from Gustavo. What we also looked at is there a difference in patients with very low blood pressure where the doctor decides to start vasopressors immediately and not give fluids, versus when they give fluids first and then start vasopressors later on? So in the questions, not the last one, but the option before that. And you can see that if you start vasopressors immediately and do less fluid resuscitation, the fluids in the first 2 hours in the group that started vasopressors immediately was 200 ml. That's hardly any fluid. You see there is a huge difference in mortality between two groups. So to sum up, Thomas showed you what the guidelines show you. And I was part of the group that made these guidelines, so I'm very much in favor. But I'm very much in favor with number 21. We recommend individualizing the target blood pressure during shock. That's what you should start with. And then I would start with optimizing blood flow. So I would add a few things. I would correct abnormal peripheral perfusion. Abnormal peripheral perfusion in the context of any blood pressure is a bad sign in shock. I would run the circulation at the lowest CVP possible, and I always try to keep the CVP less than 12 when possible. And remember, measuring CVP is not that easy, especially if you have a high PEEP, I mean, you know all the pitfalls. And I always consider permissive hypotension in a state of adequate perfusion parameters. And I always do a vasopressor and vasodilator test when my perfusion parameters remain abnormal. So in the previously hypertensive patient, I would increase blood pressure and see what happens. See if my lactate starts to fall, my SCVO2 improves, my peripheral perfusion. And in the others, I would do a vasodilator test and drop the blood pressure in these patients. And that's basically what we did in the Andromeda shock study. And so this is the sum up. The most important thing in the resuscitation of your patient is get the flow back to adequate. If then the patient still has low blood pressure, at least Martin Dunzer, Yuka Takala, Andres Brunauer, and me, we don't care that much, even if it's below 50 and 45 to 50. Thank you very much.